Today, our 84th lecture session organized by ECG Study Group under the ECG Basic and Beyond. So today, our speaker is Professor Dr.S.M.Rahiduzzaman sir, and his topic is case-based studies. Before start of the lecture session, I'd like to request Professor Rahiduzzaman sir to speak some words regarding Dr.S.M.Rahiduzzaman sir, and then we proceed on the next lecture. Rafiq Ahmed sir.
Assalamu alaikum and good evening and good morning in States. It's my pleasure to introduce Hafiz. Hafiz is a professor of medicine and program director of cardiology fellowship training program at University of Nevada, Heart Vascular. He's well known to all of us. He's also the president of American College of Cardiology, Nevada chapter. You all know him. I don't need to introduce him. So Hafiz, please proceed.
So thank you, Ravi bhai, and thank you all for coming to this session. And we'll do some didactic case discussion. This is about one of the patients that we had a few weeks ago, 58-year-old with quite a few comorbidities. And as you can see, CKD, hypertension, CVA, hypothyroidism, and then cardiology was called in for pre-op before the cholecystectomy. And this was the EKG. So this was the EKG from the ER. So you can see there is sinus rhythm, and there is QRS widen, and there is right bundle morphology. But then when she was in the hospital, the emergency response team was called in because blood pressure went up, heart rate went down, and this was the rhythm recorded. Any comment? So you can start from the top panel and go down and make a comment, see any observation.
Was there any history of the vertigo, loss of syncope like this?
No, no dizziness, no. But during the time of MARD, she felt dizzy, but not before.
Even shortness of breath?
No, no shortness of breath. So looks like if you look at the lowest panel, the heart rate really drops. What do you think, Athar bhai?
Yes, the patient has got the previous ECG shows the RBB with the first degree heart block. That is the, can you show the first ECG again, please?
Yeah. PR was 322. So there is clearly first degree AV block and the right bundle, right? What about the axis?
Yes, right axis.
So I'm sure many of you do not like this term trifascicular block, but block means delay, not block. So it is by right bundle, left posterior hemi block, and first degree AV block. So this is not a good setup. And then she went into this. So in the middle of the night with this problem, blood pressure systolic is good. So does the patient need a pacemaker? My question is, does the patient need a temporary wear? And then question is permanent. What do you do now? So when there is a mechanism like this, we ask the question about
আদিত ভাই আপনার ওখান থেকে আসছে শব্দ আসছে
So as Athar bhai pointed out, whether there was any symptom, but this is too low. When there is a question about AV nodal or infranodal block, we try to understand that whether this is infranodal, which is unreliable, or if it is AV nodal, can we counteract with medicine? Because vagal will worsen, beta blocker will worsen.
Hafiz, can you go back to the ECG, please?
Yeah.
The bradycardia. So
Yeah.
what time was it? In the middle of the night.
In the middle of the night.
Okay, and the patient was lying, sleeping happily, right?
Not sleeping. Patient is awake. Because
Why?
of the gallbladder, patient was having some pain in the belly.
Okay.
That might activate vagal tone. Mhm.
No. Just let's think a little simple. So
Mhm.
this is in the middle of the night. Patient did not pass out or did not get dizzy, right?
Right.
Okay, fine. So I mean, just if we think just simple, one possibility is vagal, but if it were vagal, we expect the blood pressure to drop a little bit also.
Correct.
It did not, but you can have isolated cardio inhibitory.
Mhm.
But this is, if you look at the top strip, there are 4 QRS complexes, P followed by QP. There is no block, except what you described before. And then
Right.
there is a pause, which one possibility you can just call, well, this is simple sinus syndrome. Or if you are imaginative, you can call a non-conducted premature beat. That will require a lot of imagination because I can't see the P wave. I cannot see any distortion of the T wave. So that's the other possibility. So the nurses were more panicky than the patient herself, right?
Correct.
Yes.
The good thing
yes,
is that the blood pressure is 190
yes. Okay.
and the patient is
Sure.
not syncopizing.
Sure. Okay.
So I just wanted to bring up this issue about, the concerning thing, whether this is a infranodal or it is a nodal block. So sometimes it is the company you keep, the right bundle and the left posterior hemiblock. There is significant conduction system disease. And in the face of that, this bradycardia, we gave the pacemaker. And after the pacemaker, this is the rhythm, the sinus and then paced. So does it help you to understand this was infranodal or nodal?
So Hafiz, patient got the pacemaker based on that indication?
Is it
Based on
temporary
the
pacemaker or
indication.
permanent? Oh, it's permanent pacemaker.
Permanent
Based-
pacemaker.
Ah,
Yeah.
Based on a nighttime bradycardia without history of syncope.
But no, not sleep, not during sleep.
No, it doesn't matter, but at night, and there is no EP study done to prove conduction problem, right?
Well, I'm coming to that, Rafiq Bhai.
Okay, sure. All right.
I'm coming to that. I'm coming to that. Echo is okay.
Okay.
And the another thing that is also in the play or was in the play is that the patient is pre-op and was going to gallbladder surgery. So there is controversies. That's why I'm going to bring you this this case. So looks like sinus and then V paste, right?
Yes.
So will that help us to make any comment that whether it was nodal or infranodal?
In this patient?
Yeah.
Well, there is definitely infranodal conduction problem because you cannot tell it by the PR interval. But if you take broad, there is a right bundle, there is left posterior fascicular block. So definitely there is infranodal conduction problem. But it was not causing any high-grade AV block. The PR itself, sometimes by the PR interval, you cannot tell whether it's infranodal or nodal. A lot of times, if there is a PR is prolonged, it's more nodal than infranodal. And the perfect example is a lot of patients with left bundle who has syncope with normal PR interval. When we do intracardiac conduction intervals, you find prolonged HV interval in the setting of a normal PR interval.
So can I add something?
Yeah.
Sometimes we get patients who have trifascicular block, but no obvious history of syncope or other things. But they are not feeling well. And if we do the anti-proBNP, we find that the patient have raised anti-proBNP more than 1,000, quite significant, but there is no other obvious cause. Could that be related to the severe bradycardia at sleep time? And will that patient need pacing for that reason? The patient actually is having a bit of heart failure.
No, I mean, we don't put pacemakers in. Trifascical about that, we have many patients. We follow them. If they have syncope, you can consider, but then you also have to be careful. If there is a 55-year-old with syncope with trifascical block versus an 85-year-old, I have more higher threshold of putting pacemaker in 55-year-old. If it is pre-syncope, you have to be careful again whether the symptom and bradycardia is related or not. The whole point is a lot of these patients may end up needing pacemaker in future, but if I can delay it by 5 years or 10 years, I'm prolonging the longevity of the battery life. And the
Excellent point, Rohit bhai.
Yeah.
We were doing some, in those patients, what is your observation? I would definitely do an echo, make sure there is no aortic stenosis. These are old patients and no diastolic dysfunction.
Exactly.
Because we did them walking to see two reasons. One is that the conduction system gets better or not, meaning heart rate. And then importantly, we did exercise related post-exercise 6 minutes walk and a BNP and see whether the BNP goes higher, because it was part of our diastolic dysfunction research. And many of them actually show a very significant increase in BNP from baseline when they do 6 minutes or 10 minutes walking. So which tells me that small dose of diuretics may help them at least symptomatically.
I think I agree with that point, because the reason is pro-BNP, we expect some sort of feeling pressure up, borderline. So there's different way to measure the feeling pressure and at rest and stress. Definitely direct way to do right heart cath and figure it out. There's one way, or when you do the heart cath, you can figure it out. But if there is a feeling pressure going up, that can explain the pro-BNP to go up for any reason, not much bradycardia itself. Second question is, yes, exercise-induced pro-BNP rise, that's a quick way out, very easy way to do it instead of going inside the right heart catheterization, because diastolic dysfunction is a major problem with that. And you can also look at another point, whether there's a dysynchrony in the ventricle. When you look at the echocardiogram, if you see how the apex is moving, how the lateral wall's coming in at the same time or not, or there's a dysynchrony, that can cause some problem with the heart failure. That can also raise pro-BNP level, but that's a different level. But echocardiogram would be the right thing to do first approach.
And the dysynchrony on this situation alone in the diastolic dysfunction, to propose a by-V paste is not going to be an easy sell to the EP guys.
That is true.
Yeah. So, and Rafiq bhai rightfully pointed out that. So, so this is the conduction system. And then, we talk about this infranodal, just for the audience, that we look at the AH and HV in our patient, the HV was more than 55. It was about 100. And therefore they decided to put the pacemaker. And also we took into consideration that the anesthesia will give hard time in terms of trifascicular block and going into surgery. But that is a small point, because sometimes you can hold their hand and say, you will be fine, keep atropine at bedside and also pacer pad, and you can fly through the surgery. But the main reason was that the HV, we proved that it was longer. Normal HV is 35 to 55. So next case.
Another point on that particular patient, prior patient, was there any role to give some dose of atropine to see was it's getting worse, the conduction?
I showed you, Aziz bhai, that what we can do to manipulate. In this case, they gave atropine And also they tried dopamine. None of
Mhm.
them did anything.
Okay.
Yeah.
So, Hafiz bhai,
Yeah.
acha, again, regarding your first case, that is without EP study, the indication was class 2B, but after EP study, it became class 1.
It definitely became class 1 or class 2A. I don't know exactly it is 1 or 2A. I leave
Okay.
it, Ravik bhai, it is a class 1 for HV more than 55,
Okay, what was the HV?
100.
Yes, sir.
Well, this is the way it is. If somebody's HV interval is a properly done HV interval is over 100, you can put a pacemaker in, because these are patients are going to be the highest risk.
Mhm.
If it is between 70 and 100, then you depend on the symptom. So if somebody comes with syncope, HV interval of 75, I would put a pacemaker in. Left bundle branch block, syncope 70, but over 100, it's basically it's an accepted indication for permanent pacemaker.
Actually, syncope is a blessing, because in that case, you probably would not even do HV interval. You just put a pacemaker.
Exactly. Trifascicular block with syncope.
Yeah.
You also have to look at the clinical scenario, but most
Yeah.
likely it is intermittent AV block.
Yeah. So this is a 66-year-old with stage 4 pancreatic cancer. And this is actually a very important issue to me, that every time we see ECG, I think the way we are grown up, like in our medical school everywhere, we read ECG like a tracing. ECG is not a tracing. ECG has to be read in the context of clinical presentation. And I'll tell you how we learn from this case. Clinical context, clinical context, clinical context. And it's very important, because ECG means that we'll be doing a series of actions, and the actions have implications. So this patient had this EKG with chest pain. Anyone? So if you look at the lower panel, because lead 2, I go to lead 2, is very good to know whether there is any rhythm issue. Looks like sinus stack, probably safe to say sinus stack. Maybe there is right bundle, and anything else.
Look at the axis.
Yeah, left
Yes, sir.
anterior.
Left ventriculaire block there.
Yeah.
Okay, so but in the past we used to do right bundle, and ISIS 1, 2, they included right bundle, then they took it off, because right bundle is still, you can have ST elevation. So right bundle alone is not good enough for calling a STEMI, because left bundle we invoke Garbosa. So here, do you think there is right bundle and anterior ST elevation? Certainly the B4, B5 raised the question, and the chest pain was really convincing. So what do you do? Next best step in his management.
Is it new onset RBB or known RBB?
New onset RBB.
Again,
Okay,
troponin.
so new onset RBB is all.
But the clinical context is very important, right?
Yeah.
I'll go for C.
So Rafiq bhai, do you want to poll, or we just move forward?
No, I think this is a question of opinion. I mean, this is first of all, patient with chest pain, right?
Yeah.
And have stage 4 pancreatic cancer.
Yeah.
So that part is important. But I mean, from my blind sense, if the patient, how old is the patient? 66. I'll probably do an angiogram, see what's going on.
Yeah. So that's what we did. But we also did echo on the way. But we saw this. Sometimes in the COVID time, we see like typical Takasubu with the inflammatory surge or stress surge, like emotional stress, sympathetic pathway, inflammatory pathway, and rarely serotonin pathway, typical classic Takasubu. But here, it is more of a regional wall motion, and LAD was occluded, which is not a surprise, correct? That the new right bundle, 10 out of 10 chest pain, and the ST segment in V5, V6 elevated with the right bundle. So the patient had the revascularization done, and then patient was doing good, and then getting lightheaded and palpitation. And this repeat EKG, and then followed by that, this EKG.
Anybody, any comment on this ECG?
Yeah, there's more A waves than V waves, and the PR interval is not very consistent. So there's some concern about dissociation going on.
Yeah, I mean, I have some comment, Hafiz, if you don't mind.
Yeah, sure.
Interesting ECG, because previous ECG showed right bundle bunch block, left anterofascicular block. This is complete heart block with left bundle pattern escape rhythm. So this brings us to the concept, we used to say complete left bundle bunch block, complete right bundle bunch block. Actually, that theory is now gone.
Yeah.
So this patient, even though had right bundle bunch block, now the conduction is through the right bundle, producing a pattern of left bundle bunch pattern. I mean, this is of theoretical interest and curiosity that in a patient with complete right bundle bunch block, how can you have a junctional escape? The reason I'm saying it's a junctional escape, if you look at the initial R wave in V1 and V2, it's narrow. And if you look at V6 and lead 1, looks almost like typical left bundle bunch block pattern. So this is interesting. The other
very good point.
The other part is that we're talking about new right bundle, new left. I don't think it really matters, because in case of left bundle, new matters. I'm not sure, Hafiz, unless you have something else to say, that new right bundle, does it matter? Because even if you block the LAD, right bundle is on the right side, and it should not affect it.
Yeah, and this is a very good point. So even if it is a new right bundle to the patient or new right bundle to the physician, that is another important thing. In the absence of previous EKG, it is expected that even if it is the proximal LAD before the first septal perforator, the occluded, the right bundle with that, you still should be able to see the ST elevation. So the criteria for right bundle and STEMI activation still remains with the ST elevation. But left bundle is problematic, as you know, that we need to do the Garbosa criteria. So we wanted to show you this because AV dissociation, when we talk about, we need to understand what is the atrial mechanism of depolarization and what is the ventricular mechanism of depolarization, and what is the relationship between AV. In ventricular tachycardia, you can have AV dissociation, but the ventricular rate will be faster. So in this case, what is the next best step now at this point? That 24 hours later, patient going this, and what you do now? While we are thinking, the patient does this. So this is actually real thing, because they are thinking about pacemaker or not, and then the nurse called the fellow back.
What is the magnesium level?
Okay, magnesium level was done later, but magnesium was given.
Okay.
And so level is not going to matter much because it was magnesium was given. I think they gave 2 grams of magnesium. But because you asked this question, will you call it a polymorphic VT or will you call it a monomorphic VT? The reason I'm saying VT, because we see narrow complex in the middle of white complex storm. So I think it is probably obvious that this is VT. Rafiq bhai, any comment?
So this makes the case very difficult. Please don't forget this patient has stage 4 pancreatic cancer. So now you stented, develop complete heart block. And the first few beats, some narrowing, this is just initiation of the VT. And then probably there is fusion beat or whatever it is, but it is sustained monomorphic VT. Sustained monomorphic VT is unlikely to be related to electrolytes or acute ischemia. The patient has scar. It's no question, it's just the substrate. But the issue would be,
I just wanted to give you a compliment. The moment you said, and this is very important, that's why every time I see a patient like this, I think the Bangladesh perspective as well. Everybody, please note that what Rafiq bhai said, this patient has pancreatic cancer stage 4, and we are doing all these. There should be a frank, open discussion with the family with empathy, because it is tough, and we are all physicians, but we also need to be pragmatic. So we did do the cath again, and I said that this is monomorphic VT, but I was not on call. My ex-fellow now attending said, no, we need to have a look. I said, oh, go ahead and look. So they did look, and I said I was sure that the stent is patent. And I don't blame him because it was his patient. He was emotional about his stent. Stent was patent. And question is, they obviously put a temporary pacer. Question is, what you do next? Will you put a device in this patient? Because of the monomorphic VT sustained little over 24 hours later, most likely scar related VT. Now what?
Sir Hafiz bhai, yes, as per guideline, if the patient's prognosis is that is survival is expected more than 1 year, then he needs it.
So I would ask the audience to look for this. Actually, it says word for word what Atar bhai just said in the guidelines. So please consult and don't jump, and do not offer ICD without talking to the expert. And this is the guidelines. We did not give ICD to that patient because the prognosis is really.
Hafiz, can I make a comment?
Yeah.
Okay, first of all, this patient has heart block. I mean, a stage 4 pancreatic, if I had stage 4 pancreatic cancer, I would rather die of VT and VF than pain of pancreatic cancer. So that will be my personal choice, short of committing suicide. Number 2, if you think that there is degree of prognosis, you can always put a live vest on this patient and give them toxic dose of amiodarone if needed. Keep it under control. I am yet to see a pancreatic. I mean, I have a couple of patients with pancreatic cancer surviving up to 2 years, but that's very rare, Hafiz, right? I mean, it is extremely rare that you see a pancreatic cancer survive beyond 1 year. So definitely not a defibrillator.
So Rafiq bhai, I did not bring up this issue about wearable ICD like a live vest because our audience, we are all from Bangladesh, and this is a secondary prophylaxis, and therefore we were little not so keen to offer live vest, but we discussed among ourselves, and actually when we went to the patient, pancreatic cancer patients may have a higher incidence of depression. Wadud is very good in internal medicine. Remind me if that is true. And the second thing is that patient knowingly wanted nothing to be done after knowing all this.
Perfect.
Yeah.
Actually, in our country, it's very obvious. We really, when you get to these situations, we always pay attention. Jim to the surgeon bolten, Baba, রুগী তো মারা যাবে, তার ফ্যামিলিকে মেরে ফেলো না।
Right.
ফাইন্যান্স।
Right. So I just recapitulate ourselves about the SA node. SA node has a 60-40 for the exam purposes. 60-40 vascular distribution. 60-40, and then the AV node is 90-10. But pay attention to the right bundle because that has a dual blood supply. So it is important to pay attention to this compared to the left anterior fascicular block. The anterior fascicle is mainly from the LAD. But this is the EKG exam test. And as Rafiq Bhai pointed out, the board really wants you to understand that atrial mechanism, ventricular mechanism, and atrioventricular relationship, and then morphology of the STs and what you can deduce from that. And uniquely, there is a column for pacemaker, which Rafiq Bhai has addressed many times, that how you diagnose pacemaker function, that is another category. One of the things that in the board exam, they really ask you heavily is whether there is any specific diagnosis you can come up with, like hyperkalemia, hypercalcemia, Brugada, and the point distribution is more for the clinical disorder, because you can get the EKG right, but if you fail to diagnose the clinical disorder, you may not get score enough. 76-year-old cabbage, and then this EKG, and then this is a ventricular paste, and I just wanted to mention this. In the EKG report, sometimes they say when they interrogate the ERI and then EOS, but I don't know whether our audience is clear with this, that elective replacement interval versus the end of service. Rafiq Bhai, do you have any comment? Because sometimes people panic. The ERI, they think, oh, pacemaker is gone, and then they admit the patient and prolonged hospitalization, which you can do as an outpatient. Rafiq Bhai, unmute.
When a pacemaker reaches elective replacement, you still have at least 3 months left battery,
Right.
full function battery. Even after that, there is life left in the pacemaker. So a pacemaker reaching ERI doesn't mean that patient has to be admitted to the hospital.
Correct. So that was a comment, but before I bombard you with this one, this is ugly. So this is ugly, but let me give you the history. 38-year-old male with history of little bit of drug abuse, and then come with this comment.
I can see the ECG. Yeah.
Can you see this?
Yeah.
It is ugly, Rafiq Bhai, is it?
Yeah.
So the question is, for the audience, I would say, please do not get intimidated with the EKG ever. Because you can say, this is white complex tachy, then it broke, and it shows sinus, and then another white complex, then sinus, another white complex. Question is, what is it? We can give a differential, white complex tachycardia. This is really wide. Any comment? We did an echocardiogram, echo was normal LV function, normal RV function, normal RV size.
Yes, Hafiz Bhai, in the sinus bit, sir, there is possibly there is pre-excitation in the sinus bit, sir, on the right side.
I mean, if you look at it in rhythm strip below, you can see some slurring of lead 2. And of course, V1, V2, V3, but the PR is not very short. So,
But when I mapped, I told the residents not the fellows. I told the if fellows do not measure the RR, they want to guess. And I tell them, fellows, it is tediously, it is important to measure the RR tediously. There is irregularly irregular RR. And this irregularity, this much, unlikely to be VT. So this was the, I wanted to show you the baseline EKG. Okay, so they did not give me the baseline, but it is a pre-excitation on the baseline. Let me.
But can you go back to the first? Is actually what Athar pointed out is if you look at.
Yeah, so I'm so sorry that as Athar Bhai pointed out, there is a delta wave in the sinus node. And this is actually a WPW. So when we scanned, we did not scan the baseline EKG, but it is irregularly irregular if you look at carefully. So one of the things that happens with the antidromic tachycardia with WPW, that the AFib is really faster than usually you see. It is about 190, 200, 210. With this degree of fast ventricular rate with irregular, you always look for in a young patient, it is actually very suggestive of WPW underlying. And in this case, it is documented in the same setting that there is pre-excitation. One of our EP physician still does not think that this is WPW alone. He accepts WPW, but he thinks there is a VT as well, Rafiq Bhai.
Yeah, it's a little bit puzzling. I'll tell you why. If we look at lead V1, the first bit is not. Can you go back, please?
Yeah. Yeah.
No, the ECG. I can't see the ECG.
This is the EKG.
No. Yeah.
Yeah, just stay there a little bit. It takes time to come up. Mhm.
Okay. If we look at lead V1, first QRS is relatively narrow, and then there is early transition. If it is true lead position, that's suspicious. But the wide QRS in V1, there is a negative possible delta wave, but the next one doesn't have. And then in V2, the initial R wave is narrow. So that's why your EP physician said, maybe not. Because if we look at lead V6, if it were pre-excited beat, initial slurring will be more, which it is not. So that is my problem, along with your EP physician.
Right, but the EP physician was involved in the case, ablated the accessory pathway, and we compromised. We are sending for a cardiac MR, Rafiq Bhai. Is it too much?
Yes. No, I'll do that. But the problem is the guy is a drug addict, and his methamphetamine, no, that's not nothing against him, but methamphetamine is a stimulant.
Yeah.
And that's the problem.
Yeah. So, you can go through the algorithm about how you diagnose the WPW left-sided pathway, right-sided pathway. B1 delta wave positive is left-sided, and then 2,3 AVA positive, then antroceptal. I'm not going into details, but I can share the slide deck if you want. But the bottom line is that we need to really clarify the patients with WPW asymptomatic, and WPW is one thing, but is symptomatic with antidromic tachycardia and higher risk for sudden cardiac death, which is pretty low, but it's still about 0.1, 0.2% per year. But when there is this degree of antidromic tachycardia white complex, there is, of course, you worry about sudden cardiac death, and you need to make sure that the patient gets the right therapy, which is ablation. So 64-year-old with heart failure with reduced ejection fraction, and then this EKG, what do you think the diagnosis is? So again, this is wide complex tachycardia. We don't see the P wave, and the RR interval is pretty irregular, actually irregularly irregular. Left bundle morphology. The VT does not usually follow a typical bundle morphology, and the axis is usually northwest. So in this case, it is FE with left bundle.
এটা এখন 100 মিলিগ্রাম করে খেতে হবে। আচ্ছা,
So FE with left bundle, and then EF is bad. How we control this FE rate? Because they feel lousy when they go into FE with fast ventricular rate, particularly with this degree of left bundle and dysynchrony. Any suggestion?
Yeah, this AFib is paroxysmal or persistent?
Well, this has happened following the recent cabbage.
And what he has been on right now, any medications? This is the first time discovered AFib?
Yeah. But the patient has a left bundle from before, so it was not a problem. You can compare. So the rate went up, and then sinus became now AFib. So what medications to give to control the rate?
What is the ejection fraction?
20%.
And it is post-op or just for a while bypass?
Few days out.
Okay. Routinely, they will try amiodarone. That's the way they do it.
Yeah, so that's what we gave, and also give Lasix.
Can you go back?
Stop cabbage.
Can you go back, please?
Can you see it now?
Yes. So what are the working diagnosis?
FE with left bundle.
Yes, because it is irregular. Yeah, perfect. And the other part is that if you look at the initial R wave, there is a tiny R in lead V2, and the initial deflection is very sharp. So both of those points towards left bundle.
Yeah. And then this is the patient with cabbage, stroke, and then lightheadedness, and this EKG.
I think we're still on the old ECG.
Can you see it?
Yeah.
So we had concern from the hospitalist that, wow, look at the P wave, ischemia causing this bradycardia, or it is just bradycardia for some reason. So how you handle this? Electricity and plumbing both, or plumbing first, then electricity? How you handle? So
the ECG changes are consequent to the Panderberg block pattern. So, depending upon the patient's symptom, I will decide whether it is ischemic origin or the conduction system is the more important.
Yeah.
Hafiz, the question is the ischemia causing this conduction problem?
Correct.
Okay. There is no P wave. And whatever P wave you can see, it's most likely retrograde P wave, right? So,
Sir, if we follow the lead to rhythm strip,
yes.
the apparent P those are being seen is positive.
Yes.
So can it be junctional, or because retrograde P should not be positive in lead 2?
And
Yes.
also the distance from the V wave and retrograde P, if you think about that, it's also different. So it's probably running separately.
Yeah. So you're right, because the first of all, POA, the variability can be described. You can have retrograde Wenkeba. But what Tushar made a point is that P wave in lead V2 in lead 2 is positive. So probably there is marked sinus bradycardia with junctional escape.
Yeah.
Again, sir,
So-
the T wave character is also against the ischemic origin, sir, as the T waves are the symmetrical T waves, and this is the point against the ischemic origin. Hafiz bhai?
So my another rule is, if it is P wave is too ugly, then it is probably not, and the patient is not having any chest pain, is dizzy. So I said that let's figure out the electrical side. We did the echocardiogram. Echo EF was preserved before, EF normal now, and we put a permanent pacemaker. Question now, after putting the permanent pacemaker, the dual chamber, this is A paced, and then you see QRS. Does it make sense to think that this was primarily a sinoatrial problem, or is it an AV problem? I think Tushar kind of went that path, and Rafiq Bhai kind of pointed out to that. And that was also our thinking, that there was a significant sinus issue also, sinus bradycardia. And then looks like the ventricular mechanism was probably junctional. And because of the underlying conduction, it appeared white QRS, but it was probably junctional. And then there was, so we put the dual chamber and patient did okay. Any comment?
No, I mean, Hafiz, you're absolutely right. I mean, it's probably the sinus or the issue. And it's very simple. When you put this pacemaker in, you can prove it in the lab. What you do, as soon as you put the atrial lead, just prove pace AI, and you can see the conduction. But keeping in mind, these patients can have both, because patient has right bundle and
Yes.
left exacerbation.
Left bundle, right
Yeah,
bundle.
left. Yeah, so can have both conduction, intermittent, complete, intermittent AV block.
So here is the question to you, Rafiq Bhai. So normally I enjoy the EP conference because on that day I just drink coffee and enjoy. In other days I'll have to participate cath and etc. So the third year fellow is asking the EP attending, so in the exam, should I write AV dissociation or we just write sinus node dysfunction?
Oh, this question will never be asked in the exam.
Well, in the mechanism, they ask you to tick.
Yes. So this one, the problem is that you will have to call it sinus node dysfunction with ventricle.
With AV dissociation, complete heart block, because junctional. If it is junctional, then technically this is complete heart block.
Well, no, not necessarily true. If you have isorhythmic AV dissociation.
But then it is dissociation. If you say AV dissociation, we are good.
Yeah, yes, there is AV dissociation question. As you said, Hafiz, you put 3 points. Does all AV dissociation mean AV block? No.
Right, exactly.
There can be competing rhythm. I think there are some competing rhythm, as Tushar pointed out, that the relationship between the P and QRS complex is changing a little bit. And if we had waited long enough on this rhythm stream, we would probably find in some place there will be some conducted P wave.
Mm-hmm. Yeah. So good academic discussion, but patient did fine. So the patient has cabbage for, and then prosthetic valve for severe AI, and then post-op went to this rhythm, post-op. This is 58-year-old. And next cases we'll go for a rapid fire because we have some questions at the end. I was feeling encouraged because at one point it was 39 or little over 40, but now the audience number has gone down. So we need to patch up. Anyone? So adenosine was given, and then a patient responded, and then we did AV nodal reentry TAC, and then AV nodal the ablation for the AV NRT, and this was the surface EKG after patient did fine. So, and I just wanted to point out that the success rate for AV nodal reentry TAC is so good and it is curable. So we need to be very careful about this and probably refer patients for ablation. Any comment?
No. I mean, AV is standard of treatment, and the complication that you quoted, I always say 1 in 200 risk of heart block, which is 0.5%. Any center having more than that will have to rethink about ablation. And success rate, we quote 95%, we quote recurrence up to 5%, but the recurrence rate, I think, is way below 1% in good hand. So this is cure once the ablation is done.
So we talked about right bundle, but let's talk about the left bundle and chest pain, and then presentation like that. So, and we talk about Garbosa. Just if you have 3 criteria, the sensitivity may go down, but the specificity will go up. So in this case, and I just put this cartoon because sometimes the residents and fellows have questions about what do you mean by discordant or what do you mean by concordance. So this is what we mean by that. And then you pay attention to all 3 criteria, then it becomes more specific. So in our patient, we did the cath, it was multivessel, went for cabbage and did fine. So let me go through another case because I'm skipping this because I have a fantastic case at the end. Pacemaker indication, let me go through the last case because okay, so maybe we can take these questions and then we'll finish. 60-year-old with the bradycardia, an electrocardiogram done. This is the EKG. And if you want to read more, cardiac exam negative. And this is the EKG.
You can put it on the poll. So let's see.
What are the questions? Can you go to the question page?
And anyone from the audience other than the faculty to take this one, volunteer? If you are brave enough to answer, our sponsor Beximco will give you a gift.
Okay. So anyone volunteer? Please raise your hand. Right or wrong, you will get the gift.
Atharva even better.
And
No one?
actually, he should.
I feel this answer also will depend on which country you are in. And even in America, which state you are in.
Tushar?
But there's some fundamental principle to that. I think that Dr. Hassan already mentioned that in one of his slides.
Yeah, so one of the things I just wanted to tell the audience that we need to work clinically, take care of patients, but also we need to pass the board. And the board always wants what is ideal, because you are conceptually thinking about the patient and you are answering the correct. So board is not saying you cannot do others, but what is singular number? What is the most appropriate next test?
Only problem, Hafiz, is that number D choice will be invalid for Bangladesh.
So board expects that we do the treadmill, that no imaging, because ST segment is readable, and the goal here is to see that the conduction system is all right. You don't need to worry about this 2-to-1. It's most likely not infranodal. So that was the...
Oh, okay, Hafiz, that's the problem.
Yeah.
Because the patient was not intermittent AV block, right? It was 2-to-1 heart block. I know what board wants. The problem is board is 3-4 years behind, but does it really make sense to do a treadmill on a person who is 2-to-1 at a resting ECG?
Yeah, but to defend the board gave a clue, because it is a otherwise asymptomatic patient. He's an avid marathon runner who exercises regularly without limitation. So this is the trick, that board actually giving some clue that don't mess around.
Yes,
so next one.
But if this patient is in Maryland, we are going to do a Lyme test because we have high incidence of Lyme disease.
Yes.
So that is the problem.
And I mean, to defend the board, Rafiq Bhai, if you are doing Lyme test, it is appropriate. But what is the most appropriate next test? So,
I think the most important thing that I'd like to comment on that, what's the easiest, quickest way we can answer that? As for example, like if I'd like to, for our audience, I'd like to give some understanding of that. Here, they want you to differentiate whether it's in the AV node or below the AV node problem, okay? If you exercise or you do any sympathetic activity that can increase your sympathetic drive, and if your AV node is good, then it's going to increase the heart rate. If you're below the node problem, then you're bombarding from top, faster heart rate, then below the node is already disease, then you'll have interruption of conduction. Then you'll see it might prolong or drop a beat. So that's the fundamental principle they wanted to differentiate with quick test. I believe that's the idea of that question.
But Wadud, interestingly, if you, I can tell you, if you go to any board review courses, in every session, primary MR, secondary MR, hypertrophic cardiomyopathy, lot of discussion, and the faculty discuss with the audience. In the EKG part, like this, the faculty, like Mike Beagle, and when Shabati Rahmatullah was alive, they say, in this session, there will be no discussion, because no discussion. They will give you the question, answer, move to the next one. So they say it is non-negotiable. It does not matter what you think. It matters what the board thinks. And the majority will dictate. So that's why it is very tricky. And Rafiq Bhai and Aziz Bhai knows if anybody does not pass the EKG part, the whole board scoring is invalid, because you fail the EKG part, you fail the whole thing. It is so important for the fellows to go the EKG right. So maybe, do you have time for 1 or 2 questions, or we go to the?
Yes, please.
Okay, so 60-year-old with paroxysmal AFib, and she was started on sotalol, and then she was brought for ambulance for emergency department with dizziness, blood pressure 120/70, potassium 3.2. And this EKG.
Hafiz, please go back. I wish they had not put the potassium level in this question.
Yes, it's to confuse you a little bit more.
No, I mean, it should be a simple thing that somebody on sotalol gets diuretics. What can happen?
Yes.
Okay, so what is which of the following should be? But I was okay, Rafiq Bhai, to give the potassium level, but I did not like the options of answer. They said IV, potassium and magnesium. So they should have changed the options a little different. But in any case, this was, anyone volunteer to take this? What is it?
I think it's from the audience or for the faculty.
No, for the audience, of course. Faculty.
From
Somebody answered IV, potassium and magnesium.
Okay, but can you tell me what is the diagnosis?
I think whoever answered the IV, potassium and magnesium probably was thinking of. Yeah, he said Tarsad.
Okay, perfect. I
You'll
think
get a
part of the
prize.
problem is that our interaction with the audience is that their microphone is not open, so they cannot talk.
So Hafiz, can you go back?
Yeah.
So you have reservation about the choice of IV, potassium and magnesium?
No. I'm saying it is too obvious. It made it so easy.
Yes,
Because
but why magnesium? That is my question.
oh yeah, that's actually a very good question. Why magnesium?
It's interesting because if you look at, we have been using magnesium for a long time in preeclampsia and eclampsia. So the primary problem is hypokalemia, but the magnesium will stabilize the membrane quickly.
Yes.
So that even if the magnesium level is low, while the potassium, because potassium will take time to replenish, and during that time, magnesium will help. We don't need a temporary transvenous pacemaker because the heart rate is already up. Electrical cardioversion is not a choice because there is no sustained arrhythmia. IV amiodarone on the top of sotalol will make the situation worse. Same will be the case of IV metoprolol. It will make the bradycardia worse and make more Tarsad. Very interesting, good case. And this is a very relevant case because in Bangladesh, we have sotalol. We use a lot of sotalol in this country. And a lot of these patients have hypertension and we have a tendency to put them on diuretics. So please watch out. Any patient on sotalol or any QT prolonging drug, we have to be careful before we put them on diuretics without potassium supplement.
And also important to mention one thing, it's bradycardia dependent arrhythmia with QT prolongation. So also if the heart rate goes too slow, that can cause this QT prolongation more, this type of medication. And particularly it was increased dose recently from 80 to 120 twice a day.
Thanks, Hafiz.
Actually,
Hafiz, I want you to ask, Hafiz, I want you to ask Hafiz.
Do you want to do, so the reason I said this, Rafiq Bhai, that it is better that if they did not give the potassium and then gave a choice like IV magnesium, the next step. But this is the last one. You can read this. Hello? what is there happening? Okay, I'll call back. And it needs to go back to the hospital ER. Thanks. Okay. So AFib and then pill in the pocket for AFib given by flecainide. So for the sake of time, what property of flecainide makes it particularly effective in the setting like a pill in the pocket? Why we use flecainide for pill in the pocket? Is it the mechanism? Is it that the flecainide shortens the action potential, shortens the refractory period, or use dependence, or increased rate of membrane depolarization, or increase in delayed after depolarization? It is not unfair because this is ACC staff, like a general cardiology. So that's why I thought this is not a bad question. It will be harder more in the EP board, but if it is in the ACC general cardiology, then it is okay to discuss. Any comment? This is going to be a superstar. If anybody from the audience can get this question right, I will personally salute you. And an award, as Atharva pointed out. Atharva actually said,
True, always.
even if you write wrong, it's still good. You can make it open for everybody. Okay.
Hafiz,
Yeah.
I think we should bring this question at a different time, but
Okay, sure, we can stop.
no, but interesting. I'll just give you audience. I think we need to bring this question. This is a very interesting, and we can combine this with the effect of the drugs.
Yeah.
Flecainide is a sodium, is a channel blocker. And so I think we should bring it with other
Yeah, maybe when you do your basic one, action potential and channel
Yes.
blockers, maybe we can bring this. Okay, yeah.
this will be a very
I
good
agree.
question for that.
Thank you. I'll stop here.
Thank you, Chaudhary Hafizhasan sir, for excellent case selection, demonstration, and explaining the scenario. We are very much delighted to have you among us. Before the end of the session, I'd like to request Professor M. Atharli sir to share his views on this lecture session. Atharli sir.
Really, we enjoyed today real life beautiful cases, practical cases. Actually, these are the cases I also face every day, almost every day. So real life beautiful cases, nicely presented and excellently it is discussed. Congratulations and thank you, Hafiz Bhai, for your excellent selection and presenting the cases. So, Tushar, we can conclude the session, but before that, we have a next session in March 12, and in that day, our presenter will be our Rafiq Ahmed sir.
And I have a request to the attendees. Those of us, those who came today, I really thank you. But could you do us a big favor? Each of you can bring two of your colleagues, at least two. So we have a above 60 number. You know, it is important, and it's important to good to see each other, but also learn, because you know, if 20 of us can bring 40 others, it will be 60. We really need to get our audience number up. And I think I will request Beximco to also encourage physicians. One of the best way to disseminate knowledge is to ensure more attendance.
Sir, before leaving the session, there's a question in the chat box. A very important issue has been taken up by Dr. Kamal Parvez. His question is, a 13-year-old child presented with VT due to myocarditis. She was hemodynamically unstable with low GCS, though the GCS marking was 15/15, he mentioned might be a little less. And the patient has one guardian, elder brother of 17-year-old boy, who refused to give consent for electrical cardioversion. So what a doctor should do ethically? A very real life scenario he has mentioned. So I'd like to request Professor Rafiq Ahmed sir to give his view, what he can do in US, and then I'd request Wadu Chaudhary sir to give our perspective. Rafiq Ahmed sir.
Well, I mean, if somebody is in the ER, hemodynamically unstable, I think Hafiz will agree that if two physicians think that this patient's life can be saved by this fairly non-invasive procedure, you can proceed with cardioversion. Because this is not an invasive procedure. And the problem is that somebody going into VF, I don't have time to go out and find the family and ask for permission to do cardioversion. It will be just like doing CPR in the street. Hafiz?
And to support Rafiq, I tell you, the final authority is by the patient. If the patient cannot say anything, then it is legally the power of attorney. The power of attorney, if the hospital does not know who the power of attorney, then the physicians can override any other wish of the family, which is not a good idea, but legally. In this case, even more, because the guardian is 17-year-old who is also a minor. So in the case of minor related, minor and then treatment issues, then it falls really on the physician. So that, but in Bangladesh, that may not apply, because you'll have to pay attention to not only the 17-year-old, also the distant relatives who will be heavy-handed. But let me have a comment. 13-year-old with VT, and then you unstable, you cardiovert for sure, but the underlying issue may be a giant cell myocarditis, particularly if there is inflammation. So you really need to think about how you treat the giant cell myocarditis. I'm suspecting that this is giant cell myocarditis. Or if it is, I mean, I can't say anything more, because in the clinical setting, like fever and then recent acute onset. But if you do an echo and you see that the RV is humongous or LV is humongously dilated, then it is not an acute problem. It is a chronic problem. Or it may have a congenital heart never been diagnosed before, and you are just seeing the VT. So it is a wide differential, but not only the VT, also start thinking about what is the underlying issue.
And so I have one question
just
to
one second. I just want to make Hafiz, Ajay, I would like to interrupt you for a second. The other part is, who is asking the family?
Yes, that's my question. They should not even ask it.
Yes, it is very important. In this kind of critical situation, we will always send the senior most person in the command to go and talk to the patient. And how am I talking to the patient? I'm going to, with utmost respect and dignity to the family, showing compassion that I mean the best interest of their patient. I cannot send an orderly, hey, by the way, tomar mayor cardioversion lagbe, tumi permission diccho kina. That is not going to work. And I think it is very, very unlikely that when we approach patients, whether we to give treatment or to withhold treatment, in both cases, we always succeed when we show compassion. Ajit.
Yes, I think the main concern is that if it is hemodynamically unstable, you really don't have to ask permission, and you really need to make sure, and you can safely ask if somebody in the room. I'm not sure what's the situation in Bangladesh, but then ask the family member to go outside when you're treating the patient, because if it's selective cases, you can ask for permission. Okay, but in unstable cases, this type of scenario, if you spend time talking to the family on the phone, by the time patient will die, you really have to act quickly.
I would like to hear Wadud and Atharvai's comment, because
yes,
you are there in the field.
Sir, due to time constraint, I request Atharli sir to give the comment in this regard and to summarize the presentation, today's presentation, because we are already around 11 p.m.
Sir, this is really, this is a routine practice. Actually, we don't seek permission for every cases
Yes.
for the cardioversion, sir. We see in the CCU or in the emergency room, we give the DC shock when it is needed. And I think the Robic sir rightly said, when the two physicians agree that this is useful for the patient, we do it. Sir, it is not our routine practice to ask the patient and to seek the permission for giving the DC cardioversion.
Okay.
Yes, sir. So this is we are towards the end, and I am thank you all the participants for being with us for quite a long time. And our next presentation will be on the 12th March, presented by none other than Professor Rahiduzzaman sir. We'd like to request our participants to present on that session. And as Dr. Chaudhry Hafizazan sir requested, we'll try to bring more and more physicians who will get benefit from these presentations. Thank you very much, all the physicians. Thank you, our panelists,
Yeah.
speaker.
Thank you, sir.
Thank you.
And
Thank you.
last but not the least, Beximco Pharmaceuticals for their continuing support on this program.
Thank you.